So we are on week 9, knowing that this week we are doing all of our reviews. Of course, they're all going to be posted. I already did my review, it's already posted, and there's actually 2 more there that you can have to go over. Anybody who wants to get with me before the exam, please let me know so I can arrange my time to be able to do that. If you want a bunker to get into your HESI, it's a good thing. Also know that next Saturday at 2 p.m., December 13th, I am doing what I call the all pediatric HESI Q&A. I go over growth and development. I go over every body system and how to think. How would questions be presented? How can you think to answer them the best way? So there, yes, I've got HESI Q&As recorded. You can listen to them if you want. If you can, come to a live review. And at the time you have a question, you can ask me and I can answer it in the best manner that I possibly can, okay? So those pediatric assessments, make sure that if you want to resubmit anything, and I've written it in the comment underneath the modules, okay? If you have a less than 100, go and look. Why is it less than? And any portion you can increase because I've put there exactly why it wasn't a perfect score, okay? Because I want you, of course, again, to have the best score you can. Bless you, Alexa. All right, let's go ahead and let's start. You know, let's see what we have to do this week. We've got another case study. Of course, it's that musculoskeletal one, a discussion question, and that dosage calculation sheet. I've put the dosage calculation sheet that you can use in the chat box. Apparently, you can't open it, so it is there. Grab it, it's yours. All right. The first one I put in when I was talked about dosage calc, I thought you were asking for exam 3 dosage calc. What are the types of questions will be there? That was the first one I presented. But the one that's there now, the second one, is just a blank 1 through 40. You can fill in all of the answers for calculate with confidence. Okie doke. Let's
Sorry,
start out.
Professor. I still don't
Sure.
have access to the actual problems. I have the worksheet, but I don't have. When I go to click, it says access denied on the announcement on week 9.
Okay, I put calculate with confidence, the worksheet over there on the right in your
Yeah,
chat box.
I have the
Okay.
worksheet, but not the like. Do we have to find it in the book or is it the
Yeah, it
problems?
should be in the book. I believe it's the
Okay.
last chapter. It's
Okay.
pediatrics. It's the last chapter, and you go to the test, and it's questions 1 through 40.
Okay.
There's
Thank you.
even the answers in there, guys. It's easy. So you've just got to look for it, all right? Okay. So we're first going to start out with musculoskeletal. I mean, these pictures, and you know, I love pictures. I'm always updating my PowerPoints, putting new pictures in because I really believe that they tell you 1,000 stories with just a little picture here. That little baby will go into that. That's a Pavlik harness, and you're going to tell me what's wrong. What is wrong with the way that that child is using that Pavlik harness? I'll give you a hint. There's no cotton t-shirt underneath to protect the skin of the movement of all of those little straps. So it's basically just putting on a onesie or a t-shirt. The one on the bottom is a spica cast. We do use those for hip dysplasia, which is the one with the top little baby. We use, of course, we have our crutches, we're going to have casts, and then we have traction. And that's that bottom picture, and that is a Buck's traction. And we use that for a fractured femur. It pulls the bones out through a weight that hangs out over the end of the bed. So When you have a child who is immobilized, they're immobilized for many different reasons. It could be something they're born with that we can't work with, that they're going to be in bed, and we have to be very careful and gingerly treat them and touch them because their bones can break very easily. One of those diagnoses is osteogenesis imperfecta. It's a brittle bone disease, which is degenerative all the time. Know that also immobilization can be caused by just being very ill, septic, in a car accident, many different things. So when they're immobilized, we've got to worry, just like adults, that there's not going to be foot drop, that the muscles don't atrophy, that the lungs stay open, that the heart keeps beating, that there's no dependent edema. So that's turning and positioning and massaging the areas, right? And then, of course, it's nutrition, giving them those proper nutrition. Children that have to be in bed or they're not able to be mobile, they become a little bit angry. They want to get up, they want to get out, they want to go be, as I say, with their buddies and them, and they can't. So you're going to see them angry and they're going to get aggressive on you. And it's only because of their condition. So need to keep them occupied. And that's where I call always child life. They'll come in, give them games, things to do, and keep them occupied, distractions. Now, there are some conditions that will be ongoing. And it's not just the child in the hospital. Remember, there's a family. There could be a brother or sister at home. Know that families have a hard time dealing with prolonged mobilization, as long as the child. So there are support groups, etc. I know the hospital I worked at, every single unit had some sort of family support group, and they met monthly. Whether it was cardiac, newborn ICU, neuro, GI, respiratory, all of them, these parents got together and they share stories. So it's very important. Makes them feel like they're not the only one fighting this long-term disease. Now, children like to get up, get out, and they love to play. And part of that is they don't warm up as best as they could. And they do have injuries, whether it's to the muscles, the ligaments, the tendons, whether it's they're just playing or if they're out playing a sports. Now, one of the things that can happen is bruising or a contusion. Now, we can look at the outward side of that ecchymotic area and say, okay, they're bruised. Well, how deep does that bruising go? Is it so much swelling that inside a vessel's being occluded and now you don't have blood flow distally? That is your biggest concern with a bruise. So, what would you be checking with any child with a bruising on an extremity, a finger, a toe? Well, we're going to be checking distally. Is there blood flow, neurovascular signs there? Okay. One of the things that children do is they dislocate their bones. I think the biggest one is that nursemaid elbow, where you're taking the toddler and you're swinging them by their arms, and their elbows get stuck straight. Their tendons are so uh, malleable and movable that the arm pops out and they cannot bend their arm, and it's painful. So they need to go in. The doctor takes the arm and manipulates it, and that's all we do, and put a little um, uh, thing on it to hold their arm, the sling, to hold their arm in place, just to let it rest. One of the children that get a lot of dislocations and have that capability is Down syndrome. Have you ever seen a Down's child, how flexible they are? They can take both legs and put them over their head. Problem, their hip joints could pop out. Even their arms, if they put them up behind their head, you can have the shoulders pop out of joints. So the problem is if they get dislocated, you can have a problem with blood supply, and that's a big deal. So with Down's children, we wouldn't stress them to do all of these big stretchings because of the possibility of dislocation. Now, I think a sprain or a strain is worse than a fracture. Um, I think a sprain is extremely painful. I've had many of them in my life, as growing up as a teenager through college and through high school. I was very active in sports. I was a captain of all the teams. I had six brothers. I had to be athletic, so I was. I can tell you I sprained my ankle, especially volleyball. Go up, spike a ball, come down, and you just land on your ankle and you just sprain it. Immediately, what happens? You feel that swelling immediately, and the pressure and the pain, and of course, the bruising that occurs because of the stretching of the tendons and the ligaments, and etc. A strain is when, for instance, you're training for something. I like to equate that to training for the Olympics. Like if you're in gymnastics, you're going to be doing that same thing over and over and over again. That's where you find these strains from that overuse. So, how do we treat it? Well, when I used to go up, spike a ball, come down on my ankle and go, oh my goodness, I've done it again because I did it almost every year as playing volleyball. I would immediately stop, sit down, and put my foot up in the air because that will decrease swelling. The acronym we use is RICE, rest it, which is what I did. The trainer used to come over and give me an ice pack immediately, and then she'd wrap it with an ace bandage, and of course I'd have it up already. Now, years ago, we didn't place any splints or casts or anything on sprains, and I had some really bad sprains. Today, we actually do put them in a splint just to rest the joint so it can heal better. So, rice, you need to know that one. So fractures in children are very common. Kids are falling down, they're clumsy, it's what they do. And how do they fall? Hands first. So, what's the most common of all of the fractures? Your wrist, whether it is a tibia, whether it's a radius or an ulna, or one or the other, or both. So, again, fractures are common for just because kids are kids. Now, the description of a fracture. The normal fracture that you usually see in a child is usually simple or closed. They fell off the monkey bars, landed on their wrists. It is swollen, it's painful. Take an x-ray and it looks like that picture down there. Boy, we got, a big break going on. That is a simple or closed. We just have to manipulate it, put on a cast, and it will heal. Now, sometimes the bone comes out of the skin. Now we're concerned because you have now let the outside environment into the skin, and now staph is usually the big infection, and it could end up with osteomyelitis and the use of a limb. So, how do we treat an open or compound fracture, the bone sticking out? Well, priority IV antibiotics. Yes, we'll do x-rays. Yes, we'll cast it. Yes, we'll do all those other things. But priority is to prevent that osteo by giving antibiotics. Now, a complicated type of fracture is that one where, for instance, I think fracturing a rib and then that bone goes into the lung. So that's complicated. So that fracture of the rib did damage the lungs, another organ. That's a good example of it. See that quite a bit. And comminuted is just a bunch of little pieces that are in there, like shattered the bone. And again, creating a lot of sharp edges in there and the nerves and the bones. It's very painful. And then another one is very similar to a strain, but it's called an avulsion. And what happens is the bone and the tendons and ligaments are pulled away. So now the bone cannot function because there's no tendons or ligaments to make it move. Okay. Now, our concern, children are still growing and they grow in their bones, and you can see now where the growth plates are. They're in those connections where they connect to each other. Okay. And if they get a fracture in this growth plate, or an epiphyseal plate, it's called, The problem is if we don't make it correct and straight, this child might have a shorter or a crooked arm, leg, finger, toe, whatever bone it is. So this one requires surgery. And we have to monitor very closely that that arm, that leg, whatever was broken is growing in the proper manner. All right. So big deal. Open reduction, internal fixation, surgery to make sure that bone is straight so that child still will grow in the way that they're supposed to. Now, look at the way children heal. That first 28 days of life, they heal bones in 2 to 3 weeks. Can you imagine? Then you get up into toddlers, preschoolers, 4 to 6 to 8 weeks. And then you go up to adolescents. Now we're up to 3 months. And I think us 3 months, 4 months, depending on our healing, etc. So knowing that, there's things that we need to take account. And I'll go into that as we get up to the one about the neonate and the healing process. So we get a fracture. What are we going to do? Well, we can't just assume the fracture was a fall. Remember, our job in being a pediatric care professional is to protect the child. We know sometimes fractures are due to child abuse. So if it's just a fracture of the arm, the child says they fell off the monkey bars, the mother say fell off the monkey bars, we know the stories match, the injury matches the story, we're good. Now, if it's not matching, that's when you should report child abuse. Go to your charge nurse, let them know what's going on. Go to the physician, let them know what's going on. Another thing with fractures, and I've learned this very well, if a kid has a broken bone in his feet, leg, arm, whatever, number one, the arm, they're not going to be able to move it. But if it's in their feet, ankles, and leg, they're not going to be able to put any pressure on it. So that's telling you they can't, it's going to be a fracture. They can put a little bit of weight, probably a bruise or a strain or something else. So our goal in fractures is to reduce it and mobilize it and make sure that we keep the function and no deformities there. So when you assess a cast being put on, one of the things that we have to do is an assessment, making sure that that cast isn't too tight, occluding blood supply. Now, I've given you the most bizarre picture of the worst case scenario, but I wanted you to understand that if we don't check the cast and we don't check for pain, pallor, pulselessness, paresthesia, paralysis, and pressure, and there's swelling and there's no pulses and it's getting pale, and now you're going to have depth of tissue, necrotic of tissue, and you could lose an arm, a leg, or wherever that cast is. So this is something we teach nurses and we teach families. The 6 Ps, you need to know those. So once we're casted, we need to teach children and the parents how to take care of them. You know, I've done many teachings on children, and I can tell you many times a child will get a fractured arm, get a cast on, go home, put on the bathing suit, and jump in the pool. And the mother wants to kill them because they have to come back, get a new cast on their arm because you can't have a wet cast. We send them home with bags to put on their arm, their leg, the short leg, the long leg cast, whatever it is, to keep it dry. We also know no lotion, no powder. Don't put anything, don't stick anything in there because it could cause abrasions and can cause, it get infected, etc. A cool hair dryer could help with the itch and that, and ice and keep it elevate once it's in there. Now, as I mentioned in the first picture, Buck's traction. Traction that we use, and that's probably the most common of all of them. And what it does, it pulls the leg. So if you have a fractured femur, the edges are sharp and your quadriceps are strong. So it pulls those bones into the muscles, into the nerves, and it hurts. So in the ER, I've actually done it, got these children on. It's a skin traction. We put the boot on and we put the weight up over the pulley, and the weight hangs freely. all right? And it pulls those bones so they go back together and it stops all of those spasming muscles from going crazy. And it could sit there until we do surgery. Now, the purpose of traction, I've just mentioned the basic one, is that to relieve the fatigue of those muscles and the pain that it's causing. And it puts those bones together, which can start the healing process. And when we do that, it prevents that deformity and the big thing, the reducing the pain, muscle spasms. So, box traction is that weight hanging over a pulley. You need to let it hang freely. It should never, ever be taken off 24 hours a day. Okay. Russell's traction is exactly Buck's, but if you look at the picture, there's just an extra place to hold where that femur is, but it still pulls it and it does the same thing, putting the bones where it needs to go. Now, the bottom picture is when a Pavlik harness doesn't work, and that one is next. Now, it's called Bryant's traction. We use this for children less than 30 pounds, where their hips, with just the normal thing we do, the Pavlik harness doesn't work. So, what it does, it puts the hips at a 90-degree angle, holds them up, trying to get those hips to abduct into the pelvis where it needs to go. And the buttocks is up just a little bit off the bed. And we can do that for children when the other Pavlik's doesn't work. Now, another thing that we can have is all sorts of distractions. It's called an external fixation device. I've seen them used to lengthen arms, lengthen legs, or from very bad fractures that we have to hold it in different pieces. And our job here is basically pin care, checking neurovascular signs, and it just takes a healing process for it to work. Children actually can be born without extremities. I actually had a friend whose daughter was born without a fibula in her leg. And because you can't just put a fibula in there, they had to do an amputation. And this girl at birth, so she never knew what it was like to have two legs. And she had a prosthesis. Now, when I met this little girl, I was a single parent with two kids, and they were about 9 and 10. And this little girl was 5 when I met her. And I lived in a 2-story townhouse. She chased my children all around the house with her prosthesis, beating them over the head. She didn't care that she didn't have a leg. So again, children adapt so well. We know sports injury are a big thing. I've already said that because they don't work up, which could cause those injuries. The overuse, those are those strains because we're doing the same thing over and over again. And then now it's that hip dysplasia. So we know that Bryant's traction is when this one doesn't work. Okay, so what is hip dysplasia? You can see the ball socket and the hip joint, and you can see it. This ball should be in that socket. Well, sometimes it is higher up. It's not completely in, and it could be at all different places. All right, so girls are more than boys with this one. What do you see? Well, the hip joint's up here, so that leg is going to be shorter, right? We're also going to see the gluteal folds or the buttocks, the cheeks. One's going to be higher than the other because of the way this is higher up, okay? You're going to see positive ortolani, positive Barlow testing on these children. You know, when you go to the pediatrician on your first visit, the doctor does that, goes up and fixes the legs and making sure he doesn't hear anything or clicking or making sure that those hips are in place. So, how do we treat? When we see a newborn baby, now that's that first 3 weeks that they heal really quick, right? So, we can put these children in this Pavlik harness. And what the goal is abduction of the hip. You need to know that word. It's abduction of the hip. It gets them to go where they need to go. And it is 23 hours a day. You can see this picture has a child with a t-shirt underneath. When we take that 23 hours a day, we take it off, bathe them, change them, we inspect the area, rub the areas that might be a little bit reddened, and then place them back in the Pavlik harness. Another thing that happens with newborns, and we need to fix it quick because of the early healing, that first 3 weeks of life, right? 4 weeks of life, is something called club foot. Now, you don't have to know all the names. Club feet is the ankles could be up, down, out, route. There could be any way. They're just not sitting what they should be. So we need to put cast on them. It's actually called a Ponseti method. And every week, remember, they heal very quickly. So every week we change the cast. It's amazing. I've actually seen these young children, and I don't know how, coming to work, and there's an infant there. Somehow they got the cast off their leg and they have to get it put back on. But again, every week it needs to be changed. As this child grows older, just to make sure that that correction was done properly, they do need to be checking with an orthopod, checking their feet, making sure they don't need corrective shoes or something like that as they get older. Now, I mentioned osteogenesis imperfecta. I've only seen one of these in my career, and it is scary. These children, sometimes just holding them underneath their ribs to pick them up, you can crack their ribs that easily. So, to take care of these kids, I would have a baby blanket underneath, and I have a nurse on the other side, and me on this side, holding the blanket up, changing the bed underneath, or changing their diaper, whatever way I had to do in order to protect this child's bone. Now, there's no cure. We think some biphosphonate or this or that helps, but these children are actually pretty alert. I can tell you that I've met many of these children on their way to the cafeteria in their electric wheelchairs, and then they have their little horns going beep, 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 get out of the way. And I know they're osteogenesis imperfecta because you can see the way their muscles and their joints are just in all of these contractures and deformities because they're always with broken bones. I mean, our goal is to try to keep them in a positional way that they can be mobile in some manner. Now, leg calf perth disease. Look at what it says. Aseptic necrosis of a femoral head, which means somehow, some way, the blood supply is not going to the head of the femur. And it's not due to an infection. So treatment, bed rest, maybe Buck's traction. It could be dietary, right? So what do we see with these children? How would we know that all of a sudden no blood supply is going to that femur head? Well, all of a sudden this child's going to be starting to limp, starting to get stiff, decreased range of motion, and the kid hasn't been in an accident, hasn't fallen down, any of that. So that's usually what we see. We'll do an x-ray and you can see the fuzz on the head of that femur where the blood's not going there. So we need to keep this femur quiet, let it rest, no weight bearing, non-steroidal and anti-inflammatories, NSAIDs, ibuprofen, naproxen, for pain and inflammation. And sometimes they'll do that Buck's traction to hold that leg straight. One of the things with that, again, is remember when we're talking about being at home, being on traction, and any condition, always remember nutrition, getting the proper protein. That makes a difference. Vitamin D, calcium for those children. Now I'm going to go over 3 different spinal problems. One of it is called kyphosis. We call that humpback, right? That is, that just humped over, kyphosis. Lordosis is the lower lumbar spine curves in. So you sort of lean backwards type thing. A lot of times these children are overweight, obese. We're going to go into a condition in neuromuscular called Duchenne muscular dystrophy that has lordosis as one of the symptoms of it. And then this is the most tested of all of the conditions, scoliosis. This is an S-shaped curvature of the spine, and it could be all different angles. The problem with scoliosis, it pushes one lung over, so the lung gets squashed and cannot expand the way it should. If that angle gets over 45%, they have to do surgery. They need to get that spine straight as we can in order to have the lungs to be able to breathe the way that they should. Okay. Now, how do we diagnose scoliosis? You might see one shoulder low, or when they hang over, you're going to see one arm hang lower than the other. And that's usually where we see it. And sometimes they do this in school, the screening, sometimes they don't. Happens a lot at that pre-adolescent growth spurt, where they grow that big 2 to 3 years, where 25% of their height and weight are at that pre-adolescent. This is when we notice scoliosis. So how do we treat it? Well, as I said, less than 45%. All right. We are going to be doing a brace. Again, there's a shirt underneath to protect the skin. Again, 23 hours a day. It's going to keep on there. And we only take it off to bathe and put it back on. And they need physical therapy, exercise. Now, if this curvature is greater than 45%, 50, 55%, that child is going to have to do surgery. And what they do is something called Harrington rods or Lukey rods. And what that does is, believe it or not, you can take a really bad S shape and almost make it straight. And this will have two rods connected to the bones of the spine. This is your log roll patient. We've heard of log rolling in foundations, right? This is the one that would need it for sure. Something between their legs, one continuous motion over to turn in position. Now, infections of the bones, we've mentioned it, that open fracture. Remember, osteomyelitis is something that can happen. We know that red painness, we'll see. We're going to see elevated white cells. This is a bacteria. This needs IV antibiotics, and it needs close monitoring. Again, this is a bone problem. So nutrition, big thing. High in protein, calcium, get them all of the vitamins and minerals that they do need. Also, it's a staph infection, osteomyelitis, 99% of the time. So we do give those aminoglycosides, which means vancomycin, which means what? Peak and trough levels. And the problem of maybe hearing loss, kidney damage. This is from the antibiotics. So you have to monitor very, very closely those IV antibiotics and how they're tolerating. Are they hearing okay? Are their blood levels of the kidneys okay? Another thing with these children is, again, long-term access. A lot of times these children have PICC lines that they go home with. And usually it takes a while to get rid of this. So again, here's your immobilized child, again, at home usually. We mentioned Ewing sarcoma, just to know it is a cancer of the bone. We treat it just like other cancers, radiation, chemo, and if it's not metastasized, they do surgery. Now, juvenile idiopathic arthritis. Everybody, I've told you, I have rheumatoid arthritis, something that I found about, I think it's about 15, 16 years ago now. And it's something that affects the bones and the joints. So, JIA, usually these children are somewhere between 1 to 3 years old when we get them when they're that juvenile, okay? And usually what we start seeing is they're getting very stiff, especially when they've been in bed all night or when they are sitting for a long time, try to get up. Sometimes they waddle when they walk because now their hips, their knees, everything's hurting them. And you might see the joint swelling and disfigurements going on there. One of the side effects that we don't think of, and I don't know if they tell you this in the adult med surge too, but with JIA, rheumatoid arthritis, there is a side effect that we need to look for called uveitis. This is a problem with the eyes. So we need to do ophthalmology checks every year to make sure that the eyes are still okay. So something that happened with me, even tried to diagnose that I had rheumatoid arthritis. There's really no definitive tests. They've got this test, that test, the other test, inflammation test, but there's really not, oh, yes, you have it. You can be positive and negative, one day after another. So it took me 6 years to be diagnosed. So that's a lot of frustration. How do we treat it? Well, number one, our goal in rheumatoid arthritis, juvenile idiopathic arthritis, is to preserve function, prevent deformities, and to relieve the symptoms, the pain, the swelling that goes on there. We take NSAIDs in order to deal with the pain and steroids when there is a bad flare, really bad pain. They'll give a dose of corticosteroids, and then maybe they'll put them on methotrexate orally or subcutaneous, or they might go to the biologic. Humira is usually the first one that they do choose. I've been on 8 different ones, and I'm now on an IV infusion. So again, you can see the frustration that can happen with parents and especially with their children. So besides medication, physical therapy, moving. The pool is my best place. It keeps my arms, my legs, my hips, my joints, my necks, my fingers, my toes. It keeps everything moving and decreases the chances of all of those, deformities going on there. Some people like heat. Some children like heat. I hate heat. I like cold. Whatever works for that child, that adult, doesn't matter, as long as we attempt to try it. And again, always try to get support your kid, your family, and understand what they're going through. Now, JIA, your body attacks joints. Lupus, your body attacks organs, and they call the skin an organ. That's why you have that butterfly rash, they call it, right? So, lupus is that young adolescent, that late school age child, usually girls, ages 10 to 19, and it probably is puberty that they go through, which starts the problem with lupus. And then, of course, there's all sorts of other stuff that can contribute it. Sunlight is a big thing that we have to be concerned about with lupus. I mean, if I had lupus and lived in South Florida, I mean, I would be slathered in, sunscreen head to toe and never go out in the sunshine, right? So this is a big deal for lupus. Now, that rash on the face, I've showed you 2 different types already. Anything rashy that looks like that, it's not just one type, one look. It looks like a rash there, okay? Usually these children that we diagnose with lupus, they come in because they start with that joint pain, stiffness, getting forgetfulness, and it could be they're already having a seizure or they have a pericarditis. So they'll test them and they're going to show these kids sometimes it's already attacked their kidneys. And of course, with kidney problems, you're going to see that renal failure proteinuria. So, how do we treat lupus? Well, let's just choose supportive. Many times they're just on steroids to treat them, and sometimes it's with the biologics with it. Our goal is to prevent exasperations, and of course, be careful with that sun out there. So, question before we go to the cahoots. Kristen is 10 years of age. She sustained a fracture in the epiphyseal plate in her right fibula when she fell out of a tree. When discussing this injury, the nurse should consider what? What is an epiphyseal plate? What's an epiphyseal plate? What's the big deal with children breaking bones? What did I tell you our biggest concern was? That growth plate, right? The other name for it is an epiphyseal plate. So the answer to this question is bone growth can be affected by this type of fracture. That's right at that epiphyseal plate, right at that growth plate. You don't want a crooked arm or a shorter arm. Okay, let's go and do a cahoots. Who'd like to win a cahoots? Who else is joining me today? I don't go and I don't look at the results. This is here for you to test your knowledge and to write down that concept that you didn't get. All right. That's why I do cahoots. All right, let's get going. Muscular skeletal. A multi. What is the priority for a nurse to assess following a cast application? Priority. Remember that part in the PowerPoint, the 6 Ps? That's your priority. It's everything. The pulses, the pain, the paralysis, movement, sensation, paresthesia. These are your 6 Ps. These are four of them, okay? A multi. Patient teaching for a child with a fractured bone that has had a new cast applied. Okay, so one of the things about casts, and we need to teach our, adult that's with them, the caregiver, and the child when they're old enough. Again, a cool hair dryer does work wonders. No powder, no lotion, no nothing inside of it. And again, if a cast get wet, it needs to be replaced. As I said, I had one kid go out the same day. Well, that same kid did it the next day again. So he had two different casts. That poor mother coming into the ER twice all weekend long. What should the nurse monitor after a soft tissue injury? You get this big soft tissue, ecchymosis, that's going on there. What do you have to worry about? Remember, we can see the surface, but we don't know what's going on inside the arm, the leg, or whatever. So, absolutely distally, we need to make sure the blood is flowing, and we do that by neurovascular checks. Good. A fracture that penetrates the skin is called. It'd be easier if it said open, right? But the name is compound. When you have a fracture that comes out of the skin, our biggest concern is osteomyelitis. A multi. Bryant's traction. So Brian's traction, we use that when Pavlik harness didn't work, and the kid now is bigger. The kid has to be less than 30 pounds, and we use that for that developmental hip dysplasia to get those hips back in joint. They elevate the hips a little bit, and they're at this right angle. And again, anytime you put any sort of traction on these children, you always check for breakdown, whether it's bucks, whether it's a Pavlik harness, whether it's anything, you always check for skin breakdown. What is the priority nursing care for a child with a compound fracture? Compound fracture, which is an open fracture. What's your priority? Remember, compound open fracture, our biggest concern is osteomyelitis. So, priority is IV antibiotics. Yes, you're going to check all the other stuff for sure, but priority, getting that infection under control. What is priority nursing care for a child who fell off a second floor balcony? You think this is crazy when I say this, but I've seen three children get on a second floor balcony, go on a chair, on a table, and then go over it onto the ground. And I've seen three different outcomes with it. So, whenever you have a big fall, whether it's a sports injury, whether it's a fall off of a balcony, your priority is to make sure that spine isn't cracked and this child was, or adult's going to be paralyzed. So, strict immobilization of that spine. That's priority to make sure that they're not going to have any sort of paralysis. Principles of managing soft tissue injury include something happened, you got a sprain, what are you going to do? So it's going to be that rice, rest, ice, compress, and elevate. Very good. An epiphyseal plate fracture in children may and the epiphyseal plate is that growth plate. So, yes, it can disrupt the growth of bones. Very good. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? So when you're in traction and you're looking for, what you're checking for. You're always checking neurovascular signs. When there's an impairment, there means that there's no blood flowing down, whether it's a weakened or an absent pulse or prolonged capillary refill. This is something you need to tell that physician immediately. A multi. How should the nurse care for the skeletal traction for a child with a fractured femur? So we've got that buck's traction on. It's pulling the leg, going up over the pulley, and the weights are hanging down there. How do you care for them? Well, you need to document how much weight's there. People can come and take things on and off. So you've got to say that, yes, the treatment that you are ordered to deliver, yes, you're delivering it. So what is the weight every shift? Also, it needs to be hanging there, just nothing touching it. And you should never remove the traction while the child's there. When caring for a 9-year-old in Buck's traction, what action by the nurse is correct? And usually Buck's traction is used for a problem with fractured femur, or sometimes it's a problem with the femoral head. But again, what are we going to do? We're going to do capillary refill, neurovascular signs every 4 hours, making sure blood is flowing where it needs to go. Very good. What position do you put the legs of an infant with hip dysplasia? Remember, it's 23 hours a day. We only take it off to bathe these children and to change their clothes and to inspect underneath everything. And it is called abduction. You need to know that word. What statement by parents indicate more teaching is needed regarding their 2-month-old with club foot? You have a 2-month-old infant with club feet. What are the parents saying that is no, that's not right, right? Needs more teaching. So this is one of those opposite questions here. Again, club feet, that Ponseti method, those castings must be changed every week because I told you they heal within 3 weeks. So if you left it on for too long, that foot's not going to be completely shaped the way it needs to go. Yes. A multi. Osteogenesis imperfecta. So, osteogenesis imperfecta is a condition that children are born with, and it's what we call brittle bone. We don't really have a treatment for it. It's just all, let's try to keep these bones not broken or keep them in an alignment where they at least can get up, get in a wheelchair, or sit up in bed or out of bed. Um, everything gets crooked, and it's a very difficult situation. We do not do physical therapy on these children because just moving bones can fracture them. What is the pathologic cause of leg calf birth disease? There's that little fuzzy top I told you about on that femoral head. So, leg calf birth is something that happens where blood stops flowing to the femoral head, but it's not due to infection. So, it's ischemic aseptic necrosis of the femoral head. Treatment, NSAIDs, traction, good diet, good nutrition, bed rest. Kyphosis. And that's called a humpback for another name. A multi. Which assessment indicates an infant has developmental dysplasia of the hip? What would you see? So the moral reflex is actually the startle reflex. It has nothing to do with the hip, just so that you know that. That's a developmental thing. They're going to have that asymmetrical leg folds. Remember that one hip, that bone is up higher out of the joint. So you have one crease up higher. And then, of course, positive Ortolani sign. Now, we all have Babinski reflex. That's the bottom of the foot, whether you're a child, whether you're an adult, but it doesn't indicate hip dysplasia. It's just the reflex that's present. Lordosis is described as and it's that lumbar spine where it goes inwards. You sort of lean backwards. As I said, we're going to see a diagnosis in neuromuscular called Duchenne's that has that. Scoliosis is what? So scoliosis is an S-shaped curvature of the spine. Again, this is something that happens right at that pre-adolescent growth spurt. Adolescents with scoliosis that have up to a 45% curvature of the spine would need to do what? How do you treat it? My daughter's best friend had scoliosis, and she had a less than 45-degree curvature. And she went through the whole process, and she did actually get her hips pretty well straightened and her back. They have to wear that brace 23 hours a day, and they have to do surgery for over 45%. So up to 45, it's a brace, physical therapy. More than that, they need to do that surgery where they put the Harrington rods down, the whole spine. It's really two little metal rods that go in there that try to hold the spine straight, try to get the lungs breathing better. A multi. Teaching for the child with scoliosis with less than 40 degrees of curvature. So a little bit of everything, right? We're going to wear that brace 23 hours a day. We're going to have a cotton shirt underneath to prevent all of the, the sweat that goes on and that rubbing of that brace that they're using. No lotion, no powder underneath. And the way that we help this with the brace is doing exercises and strengthening the muscles to help keep that spine straight. Another multi, a Pavlik harness. So again, we have a little bit of everything. Pavlik harness is used on infants with developmental dysplasia of the hip. It holds the hips in abduction. Of course, when we remove that brace, that 1 hour a day, we're going to check the skin and we're going to massage the areas to making sure there's no redness or irritation going on. What is osteomyelitis? Osteomyelitis is a bone infection, basically. Itis is an inflammation, and osteomyelitis is a bone infection inflammation. How do we treat it? Long-term IV antibiotics. Goals for juvenile idiopathic arthritis includes so basically, if you have this JIA, we want to reduce the pain and the swelling so these children can just be as normal as they possibly can. What priority action should a nurse take to a patient with a suspected spinal cord injury? I had one spinal cord injury. One Saturday morning, this 16-year-old boy is playing baseball, slid into third base. His head hit the defender's knee. And when he came to me, he, of course, was with his, on a backboard, completely immobilized. His right leg he couldn't feel, and his left leg he could barely move. His C5, C6 had an angulated, like you could see it. It should be a straight spine. It was angulated. It was pretty horrible. That child I took to an MRI in the emergency room, which we don't usually do it, but he was that bad. Well, I got him up to the unit, into the ICU on a Saturday. We had him taken care of on cervical traction to the head, those tongs put in, and he did have surgery. I went and saw him 2 weeks later. Now, my goal and the only thing my concern was that spine during that whole time he was with me. And of course, keeping that child calm, answering questions the whole time. Well, when I went to see him, he was being discharged the next day. The right leg that was completely numb had slight numbness. The left leg was fine. Now, to end that story, a year later, about this kid came into the ER looking for me just to give me a hug. He was perfect. He was playing baseball again, and everything was good. And he just wanted to thank me for being so nice. So, again, spinal cord injuries can end up paralysis, or they can end up like this boy did to me. And that I always will remember. And last question. Most common causes of spinal cord injuries are whenever you talk about injuries, right? It's always going to have motor vehicles in there. But we know children has to do the sports, and that can happen, just like my kid. Number three, Bailey. Good job, Bailey. Number two, Eli. Good job, Eli. And number one, drum roll, please. We got a C. Good job, C. And a TY. Thank you. Okay. And a Terry. All right, let's continue on. Any questions about anything? All right, let's go back to our PowerPoint and going into the neurovascular portion. So we've talked about musculoskeletal You know, that's all about bones and breaking osteo, that has to do with immobilization, that has to do with checking neurovascular signs. Okay. Now we're into neuromuscular or muscular dysfunction. You know, when we think of that, we always think of cerebral palsy. This is a child that muscles, they just can't use them the way that they want to. It happens for many different reasons. I think probably the biggest reason I've seen it occur was some sort of hypoxic episode at birth or extremely premature infants. Okay. We do know that children with CP, cerebral palsy, many of them end up epileptic. So these are the causes that your book does talk about. Gross abnormalities of the brain, some sort of occlusion. I call them brain bleeds, as those children, their brains are just so fragile. Again, it's low birth weight, that anoxia, hypoxia type thing. Those are probably the biggest reason. So how do we diagnose this? Well, any infant in the newborn ICU, especially premature, they have this protocol of checking on them developmentally. Are they where they need to be? And if they're not, then of course they're being evaluated more. I mean, it's part of why we go over growth and development, those little checks. What do they need to do of normal children? uh, Spastic cerebral palsy, that's the one that they can't control and they get excited and the arms just get so tense. This is characteristic by hypertonicity, poor posture, and difficulty maintaining balance, which mean many of these children require walkers, they require braces, they require wheelchairs in order to be mobile. They have cerebral palsy, gross motor problems, fine motor skills problems. They just are not where they need to be. They can't control themselves the way they should. Even their reflexes don't work the way they quote normal. If they're sitting in chairs, they need to be strapped in because they don't sit in the right posture. So, safety, 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 safety with these children. You know, cerebral palsy can be mild to very severe. So, our goal with CP is making sure they have the ability to move around. It's that locomotion. You know, I love this picture. This is a child with cerebral palsy. He's got splints on his lower legs, and they gave him a bicycle and he can move around. He's mobile, he's happy. Can he walk normally? I don't know, but I like the idea that he has something he can move around with. I mean, these kids need to be social and they need to be, you know, mingling, and with mobility they can. Now, how do we treat cerebral palsy? Well, just like that boy on the little bicycle, we need sometimes to brace the feet to give them that support they need to keep it in a position where they can walk or do what they need to do. They do surgery sometimes to relieve these big spasming muscles. Sometimes they use Botox, believe it or not. Sometimes they use things that are used for Parkinson, those levodopa things, due to all of the spasming, spastic stuff. Another thing with cerebral palsy, because they have a lot of children with epilepsy, you need to really take care of their teeth. Remember, phenytoin, dilantin, causes gingival hyperplasia. So again, gotta make sure their teeth are well taken care of because, of course, they still need to eat, and many of them still can eat orally. Remember, with a child with any neuromuscular disease, if we're going to let them eat orally, make sure their head is elevated. You give them extra time to chew and swallow because, again, their muscles don't work like yours and mine. And we need to keep them limber and moving, physical, occupational therapy, okay? Prognosis is depends on how severe they are. Many children with cerebral palsy that are severe, many of them, it's a pneumonia that usually causes them a death, believe it or not. Mild cerebral palsy, they can live a normal life. They can go to school, college, and be normal with, a mild thing. But our treatment will always be when we suspect physical, occupational, speech therapy. Let's give them the best opportunity to be the best that they can be. Now, ever hear in pharmacology to take folic acid to prevent neural tube deficits? If you want to get pregnant one month before, you should take folic acid. Well, a neural tube deficit is this one. Now, there's all different types, but we're just going to you call it a spina bifida, or you can call it myelomeningocele. Do you see that big blob of stuff on that lower back of that child? That's the nerves and the spinal cord, which is pulling up and pulled out. So the nerve endings in the lower extremities, they're not like they should be. So we need to be concerned about things like urine, stools, and then, of course, how are we going to, if they have no sensation, making sure mobility. This is a child that might also go into a wheelchair as they get older. As I said, the neurotubes a lot is just deficiencies in some sort of vitamins like B12 or its mom, diabetes. Now, once we get a child with that blob, as I call it, that myelomeningocele, its meninges and spinal cord are in that blob. It's pulled from the lower extremities. So, we really have to be careful. Immediately, we put these children on latex allergy because many of them require catheterization for urine. So if they're always being susceptible to latex, they can develop a bad allergy. So it's just something that we always do. Another thing we have to monitor, as I said, is the bowels. Again, they don't feel it. So they really got to make sure, when do they move their bowels? Do they need help with it, or are they moving it by themselves? These kids are normal up here. I had a little boy, Manuel Louis, I'll never forget his name. And he wasn't my child. I wasn't assigned to him, but I was in a room where a mother was standing over the warmer looking at her son that looked like that. Okay, on the belly with the blob hanging out, on a warmer monitor, and the mother was standing there crying. So I couldn't let her cry. So I went up and I said, Mom, what's the matter? She goes, I don't know if my baby's going to live. They don't know what's happening. I said, Mom, your baby is beautiful. I says, seems to me that you're a caring mother. And there might be some deficits in strength in the lower extremity, but I know you'll do everything to make that child as best as he can be. Well, the mother was thankful. And then what did I do? I said, Mom, sit down. I took the child and very loosely put it in a blanket and let her hold the child for a second. It didn't hurt the child. And the mother was like so happy that finally she was holding her newborn baby. Now, I want to tell you the end of that story. 14 years later, I'm down in the emergency room working now. I'm not in newborn ICU. And there's somebody pointing at me from, the outside where you sign into the ER. I'm working triage. And she was like, get her over here. So I go over and she says, you're Betty Boop. I am Manuel Louis' mother. I said, oh my goodness. There he was in a wheelchair. He had just gone to eighth grade prom. He was an A student. She had a picture of me about this big on a key ring holding him as a newborn. She said she'd been looking for me forever to thank me for being so nice to her. 14 years later. So do you see how you can make a difference? This kid, alert. He hugged me. He said, thank you. Mommy told me all about you and how you helped her. Thank you. Okay? That's a myelomeningocele. Again, taking folic acid helps. Now, I'm going to mention a couple spinal dystrophies here. One of these is Werding-Hoffmann. This is a floppy infant syndrome. This child has no fine gross motor skills, never will. It's a progressive weakness. Uh, Muscles don't work at all, and they usually die before they're 2 years old. It's a horrible diagnosis. Now, the most tested of all of the neuromuscular conditions is Duchenne muscular dystrophy. It's called pseudo hypertrophic muscular dystrophy. Mommy gives it to the boy, and we usually determine that they have this condition about ages 3 to about 7. What we will see is this is a child that developmentally might be a little behind because cognitively they do have some issues here. So they might be a little behind, but then all of a sudden they start going backwards in their progression. They might have been able to walk a step or two. Now they're falling. Now they're not able to get up. Many times we see these big calf muscles and hypertrophic muscles there. This is a progressive muscle wasting. What is a muscle? Your heart, your diaphragm. So, about teenagers, these children will die. But how do we treat them? How do we get them to there? How do we, number one, let's diagnose them. Let's treat them and get them as living as long and as healthy as we can. That is the goal in Duchenne muscular dystrophy. Well, determining if they have Duchenne muscular dystrophy, they do something called an electromyography. This is either probes or maybe tiny little like acupuncture needles, and they put it all over the body on nerves to see if I give a stimulation, a shock to this muscle, how long does it take for the muscle to respond? Now, in Duchenne's, it's going to be prolonged because it's muscle wasting. Okay. Now, these children, when they come back from this test, feel like they ran a marathon. So they hurt. So make sure you give them Tylenol, ibuprofen, something when they come back because it hurts, and to let them know it's they just ran a marathon. So it's going to take a while for them to feel a little better. The signs that we see is what we call that waddling gait when they were walking, the falling, like I said. And do you know what Gower's sign is? I do it all the time. You get on the floor and you have to get up, and you can't just stand up. You take your hands and you walk up your legs. That's Gower's sign. It's like getting your hands and putting on the couch to pull yourself up, but you're in the middle of the floor. There's nothing around you. You go walking up your legs, which helps you stand up. That's Gower's sign. They also have that lordosis, that inward curvature of the lumbar spine. As I said, those thighs are going to be big. As I said, there's going to be a little bit of mental impairment from mild to moderate. And because of the lack of movement, these children do tend to be obese. Now, treatment, basically symptomatic. There's really no cure. So it's just a lot of exercise. It's a lot of safety that we go on with these children. It's also a lot of genetic counseling so that this family knows why this has happened to them. Okay. And then Guillain-Barré. I don't know if you studied this in med-surg yet, but usually these children 4 to 10, and what happens is the nerves stop working from the feet and it works upward, and then it gets up to the phrenic nerve, and now you're not going to be able to breathe. That's the big deal with Guillain-Barré. So what do you see with these children? Well, initially, you're going to see them with lower leg weakness, numbness, that they'll feel down there. And it's going to move up. And then you might start to see incontinence, constipation. And then it hits the phrenic nerve. Okay. And then they stop breathing. So, nursing care. Well, this child must be on a O2 saturation monitor because this child eventually is going to stop breathing. These children are always placed in an ICU or at least a minimum of step down in the beginning. They will end up intubated. They are totally awake and alert, and they can't move anything. They can't breathe. They get intubated to breathe, or sometimes it's long, they'll put in a trach. If it's over 2 weeks, they'll put a tracheostomy in these children. Now, they completely can't move, starting from the feet, ascending up. Okay. All of a sudden, you're going to start see the ventilator starts, extra breath starts happening, which means now this child is breathing. So now we know that that problem with the nerves is going down and going away. We're going to give steroids. We're going to give IVIG. We're going to have them ventilated, doing whatever we need to do to keep them healthy, put them on those special beds, Foley catheter, whatever we have to do in order to get these children now turning around the other way. And then it will be, depending on how long they were immobile, physical therapy, etc. Now, tetanus. Tetanus is also called lockjaw. And the reason is the muscles in the neck get swollen and hard and tense, and it smothers the trachea, so you can't breathe. Okay? This is a child that didn't get a tetanus shot. Maybe they stepped on a rusty nail. I mean, that old, saying that says about it. So how do we treat it? Well, we're going to be given the tetanus toxoid vaccine, of course. Sometimes around the area, they put this also in there. Remember, that wound, whatever caused the tetanus, you still need to treat it. Soap and water, antibiotic ointment, right? These children are extremely, extremely ill. So if they make it, you're going to see them. If they make it to day 4, they're going to be okay usually. But many of them don't. This is a very serious condition. So during this tetanus outbreak and they're in the ICU, they're going to be ventilated. This is your immobile child. So again, doing the turning, positioning, monitoring fluid balance, not too much fluid for the brain, right? Giving that tetanus, changing that wound, cleaning that wound. And because this is so painful, this spasming into the neck, that lockjaw, we actually give medications that will just stop them from moving. So it relaxes the muscles so the child's not going to feel the pain. And we call that pancuronium or pavulon. But there's many different muscles relaxers that could be used. Another thing we have is botulism in infants. And this is usually due to a child that's under the age of 1 that's received honey or light or dark corn syrup, which was contaminated. Okay. What happens with these children? This is another kid who starts out with weakness, dizziness, headache, speech problem, vomiting, and then their respiratory system stops breathing. So you can see it again. ICU, intubated. We're going to give that IV botulism immunoglobulin. We are going to ventilate them to keep their lungs moving. And in any condition like this, whether it's botulism or tetanus, nutrition, nutrition, nutrition. And they'll continue to be ventilated until the botulism is under control. Now, that spinal cord injuries, that poor little guy, can you see that x-ray on the bottom? That basically looked like the kid that I got, where I was the primary trauma nurse on duty, and he was my responsibility, and I prevented him from being a cripple for the rest of his life. And I'm very proud of that because he was scary. But I took control of the neck and the movement and the counting and everything. Now, spinal cord injuries can be due to sports. We've already determined that. Motor vehicles, yeah, that can always happen. But what about when they come out of the birth canal? We pull on the head, don't we? That can happen. And then, of course, just falling down type things. And that hyperextension, hyperflexion extension, that's that coop to coo. That's like in a car, you get hit and your head goes back and forth. That can also cause spinal cord injuries. So, priority, priority, priority. Suspected spinal cord injury, properly immobilize. You will see that fire rescue on the scene will put on collars, put them on a backboard, tape them to the backboard so they can't move. So by the time they get to me, the trauma center, I'm going to have to get them calm, relax, tell them what I'm doing and what's happening. So, a progressive infantile spinal muscular atrophy and the most common paralytic form of floppy infant. This is the bad one. Do you remember the name? It's Werdnig
See,
Hoffman. It's Werdnig Hoffman. C. That's the floppy infant bad one. They die before age of 2. Duchenne muscular dystrophy is boys. Ages 3 to 7, we usually determine it. And we get the diagnosis from the EMG. All right, let's go to our cahoots. Who wants to win this one? Come on, Barbara. You want to do this one? Maybe. You're smiling. I see you. All right, let me get it pulled up. So, do you like doing the cahoots in between each chapter? Does that help you understand things a little better? Good.
yes.
I'm very glad with that. I mean, any sort of, you know, what you guys would like me to do differently, I'm always willing to do it. And again, I told you, this is from a student who told me to do this. And I've literally redone the cahoots, all of them. Have you all seen the cahoots weeks 1 through 9 and the 2 HESI cahoots I've sent you out today in a PowerPoint? And a PowerPoint for next Saturday's HESI Q&A. I've sent them out today. They're there for you to start studying. If you do those HESI cahoots, both those hundreds, you have every concept you need for that exam. So neuromuscular. Goals for juvenile idiopathic arthritis includes so again, JIA, JRA, whatever you want to call it, the whole thing is the body's attacking the joints. So we want to decrease joint pain and swelling for sure. A multi-select. What might you anticipate for a child diagnosed with JIA? So, with a child with JIA, we know that it's all about the joints. Absolutely, you're going to see disfigurement usually. I'm lucky I have minimal. In these little fingers, I have a little crooked, but not bad. I'm very blessed. We know that there's stiffness in the joints, like the hips are joints, so difficulty walking. And don't forget the eyes. It's that uveitis, it's that redness that you see, and we need to do the ophthalmology checks on it. A facial rash is lupus, has nothing to do with JIA, okay? What is cerebral palsy? So, cerebral palsy is all about muscle strength, movement, and coordination. Again, with that being said, remember one of our biggest concerns with a child with cerebral palsy is safety, safety, right? Protecting them from falls. A multi. What are the signs and symptoms of spastic cerebral palsy? When I was doing clinicals for Fortis, we went to this PPAC, and there was a little boy named Jonathan, and he was a non-verbal cerebral palsy child. That child got to know me, and when he used to see me, he was so spastic. He would like this, and his arms would come up, and he would shake, and he would smile from ear to ear, waiting for me to give him a hug. I mean, it's just part of what you see with them. That's the hypertonicity that you see. Of course, as I said, poor posture, making sure that we do use seat belts and whatever we need. Poor fine motor skills, they're not going to be doing with their hands as much as a child without CP. And of course, that poor balance is part of the poor posture. A multi. When feeding a child with cerebral palsy, what's important to remember? I mean, not all children feed orally with cerebral palsy. Many of them, like my Jonathan, he couldn't eat orally. He was only a gastrostomy tube. But he was more severe. You've got these mild children with cerebral palsy. Let's think about what is cerebral palsy? It's a problem with muscle coordination. The muscles don't work the way they should. So, if I'm going to feed a child with this condition, as I said, elevate the head of the bed and give them time to chew and to swallow because they're going to gag and choke. We're going to use actually thickened liquids. They're easier to swallow. And as I said, you don't always need gastrostomy feedings. If it's a child who couldn't completely eat by mouth, it might be half and half. But if we can feed them, just be careful and give them time to eat. A myelomeningocele. So a myelomeningocele is that hernia, that big blob of, you know, on the lower back, the lumbar area. It's a hernia, which includes the spinal cord and the meninges. And when you think about myelomeningocele, remember, we've pulled those nerves from the bottom to be able to get it up and outside the body. What is our goal with a myelomeningocele, a gastroschisis, a urinary exstrophy, a bladder exstrophy? These are the insides of the body born on the outside. Your goal is going to be saline, sterile at the bedside, moist, sterile dressings, and to keep the skin integrity around the area. So when we close it, the skin is good, okay? Myelomeningocele. That's just the treatment of that blob that's in the back, which is their spinal cord and their meninges there, keeping it wet, moist, and sterile. A multi. What can help a child with lupus prevent exacerbations? So again, with lupus, a lot of it is preventative. That's the prophylactic before any procedures. Wearing sunscreen and decreasing exposure, yes, part of it. Diet does not have to do with lupus at all. Infants with a myelomeningocele demonstrate what? Myelomeningocele. You've got your meninges and your spinal cord in that sac in the lower extremities where it's pulled up, all of that stuff. What are you going to feel? Or not? So it's sensory and motor impairments. Remember, they can't feel down there. They can't feel to urinate. They can't feel to defecate. They can't feel their feet, making sure that we're not, compressing them or hurting their lower legs. There could be a little feeling or no feeling. So again, myelomeningocele. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? What's the biggest thing you got to worry about? It's all about urinary retention. That's the biggest thing. I mean, yes, we're going to make sure that there's no skin breakdown, turning, positioning, and those things. Yes, but our big thing is we don't want the urinary bladder to be full and not being emptied. A key feature of Duchenne muscular dystrophy is. So Duchenne muscular dystrophy is all about muscles that are progressively wasting. Now, what is a muscle? A heart and the diaphragm. So usually as a teenager, the heart stops working or the diaphragm stops functioning. So those are the things that we are concerned about as they get older. One of the procedures that a child with possible Duchenne's may need to diagnose the condition is what? So it's called an EMG, an electromyography. Many, many years ago, I had pain in my neck from a car accident, and I had these shooting pains in my arm, and I had an EMG done. Let me tell you, you feel those nerve shocks going up the arm, and it is quite uncomfortable. Remember that this child's going to feel like they ran a marathon because they're checking all the muscles all over the place. So again, offer them some acetaminophen, ibuprofen, something, heat, cold, whatever they want, because their muscles are going to hurt after that test. How is Duchenne muscular dystrophy inherited? So Duchenne muscular dystrophy is given to the boy from mommy. Now, what would you say? You've got a child who's now been diagnosed with Duchenne muscular dystrophy, and the mother tells you, but we really wanted to have more children. This is where they have to go and do genetics and find out what's going on and possibilities for it. because if they have another boy, most likely they're going to have Duchenne muscular dystrophy. So send them for genetics. In caring for a patient with Guillain-Barré, the priority concern is what? So remember, Guillain-Barré, you're going to start out with your feet starting getting numb, and then it works up, and it's all about nerves. And all of a sudden, the phrenic nerve stops working. So our biggest priority is monitoring the airway. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? And we call this ascending, which means it starts at the feet and it ascends upwards. When all of a sudden the Guillain-Barré is going away, it descends backwards and then the nerves go back down. That's descending. Ascending is where it starts. A multi. Treatment for Guillain-Barré include? I saw one of my nursing supervisors. I think she was 28 years old at the time. She ended up with Guillain-Barré and ended up admitted to the hospital where she worked. And of course, I was a supervisor there too. And it was interesting to watch her go from this shuffling, falling down to be intubated on a rotorest bed and all of the things that needed to be done. Now, Guillain-Barré is not a bacteria, so you don't need antibiotics. Usually they say Guillain-Barré, they've had some sort of upper respiratory, some viral something like a month before. So it is not antibiotics. Would we use heparin? Maybe to prevent clots, but it's not the treatment specific for Guillain-Barré. It's IVIG, maybe steroids, and absolutely we have to maintain the airway, be respiratory support, usually intubated, whether it's with an ET tube or eventually a tracheostomy. What type of cerebral palsy causes hypertonicity and poor fine motor skills? Hypertonicity of my little Jonathan. And it is called spastic. Remember, spastic and hypertonicity. It's about the same thing. What priority action should a nurse take to a patient with a suspected spinal cord injury? And again, spinal cord injury, you're worried about it. The big thing is to prevent any paralysis, and we do that by immobilizing the spine. You should get a tetanus shot every how many years? Since I've been a nurse, this has changed many different times. I think it used to be 2 years, many years ago. And then they changed it to 5 years. And then they added the diphtheria on it, and now it's every 10 years. So it's tetanus with diphtheria, which is a symptom of tetanus. Remember, tetanus is lockjaw. What happens is the muscles in the neck get stiff and spasm and occlude the trachea, which stops problems with breathing, okay? And let's see how we did here today. Bailey again. Good job. Number two, a C. And who did number one? Drum roll. Bing. Thank you. TY. And Terry and another Y. All right. Well, I've done all the things I needed to do today. We still have a couple more minutes. Is there anything that you would like to go over before the exam? Would you like me to pull up for 15 minutes, pull up the study guide and go over a little bit of last week's information, the GIGU, because you didn't get quote the lecture because it was Thanksgiving? Would you like to do that? Let me find it. You know what I'm going to do? Let's pull up the cahoots for GI. That is a big one. And I think that's going to be exactly what you need in order for your exam. We can go over about half of this. When it comes to about 4:35, I'm going to let you go at that point. How does that sound? I know it's week 9, it's Friday. You guys are exhausted. You've had a heck of a week. I know. There are quite a few questions here. I'm going to go over it very quickly. Okay? All right, let's just get going. Again, this is the GU from last week, and I think this is going to help you for your exam next week. All of the followings are symptoms of dehydration in an infant. When you look at infants, you look at adults, there are some differences in it, okay? With infants, dehydration, you're going to see no tears, and your fontanelle's going to be depressed. Those are two things you don't see in adults, do you? You're going to see that pale, dry skin, that skin tenting, that loss of elasticity, that weakness and lethargy. What is priority treatment for a child with dehydration due to profuse vomiting? So if they're vomiting, are we going to give them something by mouth? Or are we going to give them IV? That's what I'm asking here. I say if you keep feeding them, guess what? They're going to keep vomiting. So you need IV fluids. Be careful with IV fluids. When you have dehydration, and remember, dehydration is really bad and it causes renal failure in children. So we want to replace fluids quick, but never, ever give potassium unless that child is voiding or unless you have a potassium level. And also, you never bolus dextrose. Okay. And when you are starting this IV, we want to know how bad they are. Get yourself some basic metabolic profile, your electrolytes. A multi. What physical assessment of dehydration might you see in an infant? What did I just tell you? So pink cheeks, no, they're going to be pale, but that skin tinting, absolutely. Sunken eyes, sunken fontanelle, very good. Another multi. What type of fluids would you bolus for a child with severe dehydration? So you're never going to give dextrose. You're never going to give potassium when you bolus. Normal saline ringers are both perfect to give. Another multi. What lab test can confirm a diagnosis of dehydration? That basic metabolic profile is going to tell you electrolytes, the urine, are we specific gravity elevated, kidneys, how your BUN going on. Liver has nothing to do with dehydration or fluid balance. What is the treatment for an infant with diarrhea lasting for 4 days? So remember diarrhea. It's not vomiting. So you can give those fluids orally. And we do give them orally, whether it's Pedialyte, Powerade, Gatorade, and an electrolyte oral solution. Absolutely, we do it. And that is the treatment for diarrhea. And they give a lactobacillus for the diarrhea every day until the diarrhea stops. And of course, increasing the diet because you want to feed a diet, or else it's just going to be liquid coming diarrhea all the time. So you start to feed them bland food. What acid base imbalance might you see with a child who's having profuse diarrhea? I've told you before, I have seen on a HESI 4 questions on one HESI, 4 questions on acid base. Remember, when you're having diarrhea, you're getting rid of those enzymes for digestion, and they are alkaline. So you're losing alkaline. So what is left? Acidosis. When you're vomiting, you vomit acid. So what do you have? What metabolic acid base problem? Well, you lost your acid. So now metabolic alkalosis. You need to remember it that way. Okay. A multi. If an infant has not passed the meconium stool within the first 24 to 36 hours, what would you assess for? Hypothyroidism, cystic fibrosis, and Hirschsprung's disease are the three big ones. It's the megacolon, the Hirschsprung's, right? Those are the three ones that we're going to be testing for. Electrolytes have nothing to do with the stool being passed at all. A deficiency of vitamin D causes. So it's called rickets. Know that, children can have deficiencies of anything. A lot has to do what they're eating, or they can't have because they're vegetarian, they're not eating this, or they're lactose intolerant, they can't have milk. I mean, those things have to be replaced in different ways. Proper hepatitis dietary education include all but what? So the liver causes hepatitis. The liver produces bile, which helps digest fat. So if you've got a problem with your liver, you're not going to secrete enough bile to digest fat. So your diet is going to be low fat, high carb, high protein, okay? And again, very good. That's what you're not going to do because you get gas and bloating. Multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? So this child's vomiting. He's unable to eat or drink. So the treatment, we're going to give IV fluids. And you're going to draw that basic metabolic profile to see where you are with the electrolytes for dehydration. A multi. What nursing management would you anticipate for a child with a ruptured appendix postoperatively? So you got a kid, went to surgery, and by the time they got there, the appendix busted. All of that debris has gone into the peritoneal cavity, causing peritonitis. So what do we have to do for this child? Priority. IV antibiotics, priority. And we're going to have NG tube suction because that gastric acid will go into the intestines and it's already upset because everything that it's been hit with, all of those things from the appendix bursting in there. So NG tube, keep it a very empty colon is what they want to do. Also, that peritoneal cavity was infected. And when they closed the wound, it was two infected sides they closed. So the chances of dehiscing is large. I've seen it one time where it did dehiss. So you must make sure you do assess that surgical site, the sutures. What findings in a newborn would lead you to suspect cystic fibrosis? Oh, this question is not a good question. Next, sorry. I forgot to remove it. Multi. What is Hirschsprung's disease? So Hirschsprung's disease is usually determined at birth, not always, but many times, because Hirschsprung's is this piece of descending colon that has no nerves. It's alive, it's pink, but it doesn't work. It doesn't squeeze peristalsis because there's no nerves in the area. So it's called congenital absence of the nerve cells, basically. A multi. When teaching parents about Hirschsprung's disease, the nurse would include what? So you've got this piece of bowel that doesn't squeeze and do peristalsis. So it's causing this big bowel obstruction. So how are we going to treat it? Well, we need to take that piece out because it doesn't work. Hopefully, we can connect it to the bottom piece or we can put it up and have a colostomy. So Hirschsprung's causes that bowel obstruction. We need to, in the future, make sure that bowels are moving. And many times it's a two-stage surgery. If it was a pull through where we could just take that in, take off that piece that's bad, connect it to the bottom, we call that a pull through, but it's not always possible. They tried to close this colostomy before they potty trained. And we do not treat children with laxatives and enemas routinely. We only do that for an emergency thing. We don't do every day or once a week. No. Can you imagine giving laxatives to a child? What would they need by the time they're 80 years old? Dynamite. So we don't start early with that. What type of stools would an infant with Hirschsprung's disease have? The big dilated colon and then a tiny little opening to the anal sphincter. And it's called ribbon shaped. That little tiny little thing that's left, it just squirts a little bit ribbon shaped. I call it like a frosting, which is a condition that occurs mainly in children when the intestines telescope into itself. And that is called intussusception. Remember when it telescopes, it sort of pushes out this current jelly into the diaper or into a their underwear. It's one of the signs that, yes, absolutely. It's current jelly, maybe a little bit of blood streaks in it. A multi. A 2-month-old has GERD and it's been treated by thickening the formula with that rice cereal. How do you know that's working? I mean, they're spitting up, is basically what GERD is. So they thickened the formula. How do you know that that is helping the child? And it's the child's not spitting up as much and they're gaining weight. That gaining weight is the big thing. It's as simple as that. They're not spitting up and they're gaining weight. How do you decrease the incidence of enterobiasis in children? What is enterobiasis? Enterobiasis is pinworms. They're these tiny, itsy bitsy little worms that the children go outside and they play in the dirt, and those little eggs get underneath their nails and they're in their mouth with their fingers, and then all of a sudden these eggs hatch and they come out the rectum, creating the worst itching, and usually at night in these children. To diagnose this, we need to take a flashlight and a piece of scotch tape at night and go in there in the anus and push that scotch tape there to try to get a tiny little worm to show, and we could be treated. The problem with this is if a kid gets this, the whole family probably will get it too. And we treat this by simply keeping their nails short. That will prevent nails from going, eggs from going underneath their nails and them eating them. And I'm doing one more question and we're done. What are the signs and symptoms of enterobiasis? How did I tell you you know your kid has pinworms? And we know that because it's got all of that itching going on there. All right, let's stop here. Give me 1 second. So I just gave you a quick brief over some of the GI stuff because I know last week was Thanksgiving. I don't know if you all had a chance to really look over it. And I know there was some questions regarding those GI things. So I thought I'd give you a little bit for that. Um, know that next week is your exam. Come to class a little bit early. Make sure you have 2 devices and that they're charged properly. If you are going to be testing on your campus, I have to know 3 days in advance. Who's doing it? They need to email me, and you need to let me know who you have set up to do your proctor. Okay? Any questions for me about anything? Guys, have a great weekend. Thank you.
Thank you.
My pleasure.